So the first will be Dr. James Pingpank, who's an associate professor of surgery at the University of Pittsburgh and the co-director of their complex general surgical oncology fellowship, and he's going to speak about fellowship in surgical oncology.
Great, thank you. First of all, those are two very nice introductions, and I think they're very important because it really hits all the salient points that we have with regard to training, with regard to this. And there's a lot of overlap we're going to hear from different people. And just in the form of disclosures, I am our co-director of our fellowship. I'm also on our faculty for our HPB fellowship, and I'm on the training committee for the SSO as well as the program directors. So what I'm going to try and talk today is mostly about how we approach things from the SSO, not how we necessarily do things at UPMC, which hopefully are the same anyway. So the benefits of surgical oncology training, we think, are for folks who are at the end of their general surgery training, is that it really allows multidisciplinary patient care to be incorporated into your training. And so much of, especially with decreased work hours, but also with residents being pulled in so many directions, that the ability to really concentrate on outpatient care, working up patients, following up patients, counseling patients, all that multidisciplinary aspect of things is really something that's harder and harder to do as residents. It was hard for me to do as a resident, and the level of technology was much less then, and the information was much less then. So I think it's even harder now to do. And so we really concentrate on that multidisciplinary aspect of things. And it's for two reasons. One, it's a great way to train, but most importantly, it's also what's evolved as better patient care. So multidisciplinary care is better for the patient, and as the residents and fellows tag along, they get to learn all this stuff just in the same environment the residents are, and the patients are. There are certain things which are becoming more and more applicable in the rest of the hospitals around the country that are used to be very much limited to very isolated cancer centers, regional delivery of chemotherapy, chemoembolization, and those things now are being brought out to multiple different hospitals, and this is a place to train and do them in an area of specialized care. And now, for the first time last year, our fellows graduated with the potential to become board certified. I don't think that made a big difference for my generation, but as credentialing and the ability to do cases it become more and more of a big deal, I think that being board certified is going to be something which is going to be very important as quality metrics move forward. So the modern, and there's really two tracks you can take as academic surgical oncologist. I will also say the SSO has a breast fellowship track, but I won't talk about that because obviously this is all people who are interested in GI malignancies. But one, the modern academic surgical oncologist, so much of what we see now in general surgery is cancer related and has always been, but it really is, and the reason we've titled our fellowship Complex General Surgical Oncology is it is really general surgery based. And so it is a very good opportunity for people who are interested in staying in general surgery and are interested in general surgery education and training to maintain a very active role in that. For physicians and physician training who are interested in really developing scientific career, the genetics, the biology of treatment of cancer is really something that continues to evolve. So from a research standpoint, as a surgeon scientist, there are really many opportunities for having that hybrid career of academic medicine, either with your academic component being clinical trials, translational outcomes, and so that is something that is really applicable to or available to people with SSO training. And then, leadership, not just within general surgery, but within cancer centers. And I think that every institution is different, but more and more institutions are having surgical oncology be a significant part of their leadership. And so that's another career path that people have. And you'll hear from MIS folks, but I think that for many, many years, MIS really was not part of cancer management for a variety of reasons, all of which are probably turning out to be in error. But as the technology gets better and everything, some of the more advanced MIS procedures are now getting pushed forward very aggressively into the cancer population. And so that is something that traditionally had been lacking in a lot of surgical oncology fellowships, but now is coming back into fellowships more and more. So something that you can get as part of your surgical oncology development. And then for clinical surgical oncologists, so the other component of surgical oncology is, for those of us who love general surgery and really did a fellowship for numerous reasons, including hopefully not having to do a lot of cases in the middle of the night, surgical oncology still is a very general surgery-based practice, but you can specialize in a multitude of directions. Breast and benign breast diseases, melanoma and skin care, sarcoma, upper GI, colorectal, and so all those pathways are available to people who are coming through general surgical oncology, or you can just specifically be a general surgical oncologist. And the vast majority of our fellows go out and are GI surgical oncologists. That's what they do. They do complex GI surgery in a variety of ways, and a small percentage of them will be pure hepatobiliary from the outset. But we really think that this ability to do everything really enhances people's ability to get jobs because they can go into the call pool, they can build a practice that's highly specialized while they're in a position of being able to essentially handle everything. There are multiple avenues for outreach into the community to really, the thing that's lacking, I think, as a resident is your sort of involvement in the community, but you really, as you become more adult in your specialty, have the ability to go out and interact with the community, educate patients, educate families, and also represent cancer patients on a local and national level politically. So some of this is a little different, a little repetitive, and this is really a key point. We're probably the last group to switch from the fifth year PGY5 match to the PGY4 match, and part of that is just because we were very late to move to the ACGME system, and so it's very cumbersome to move from a fall cycle to a winter-spring cycle. So this year we are matching with interviews in the summer and the fall for the August 2016 start date, but then we will then 4 months later start matching and interviewing people for the following year so that we fall into the fourth year match so that everyone will be matching in their fourth year. As I'm sure people are going to mention, that becomes troubling for residents because you really need your letters and your applications and everything in early. You haven't done your chief year rotations, and those endorsements can be harder to come. All I can say is that we kind of fought it, but that's where it's going. And the other thing is with the ERAS system, this is a rolling system. There are now 26 programs. When I applied, there were 12. And you could kind of pick and choose an interview at every place if you wanted to, and then decide after you interviewed. The schedule is so condensed that residents really have to do the research beforehand so they know where they want to interview, because there are dates now where in 3 different calendar dates in a row, 5 or 6 programs are interviewing. So you can't interview at all those programs. And so, and we as a fellowship program will get 100 applicants or 85 applicants for our 30 interview spots. And it's competitive on both ends. We want the best candidates to interview with us, and so if somebody comes in and is clearly a candidate, we're going to offer spots. And every once in a while, someone gets their application in on time, but we don't have any more interview spots left. So I'd encourage everyone to have their applications ready to go in so that we can see them as soon as they're ready. And for U.S. applicants, about 66% of applicants matched this year, or exactly 66. What are we looking for? It's really hard to say. You kind of know it when you see it, but you can tell by people's letters and what they've done in their careers and what they want to do. And the really thing we want to see is curiosity and accomplishment. I mean, people who sort of have that drive, who have done research and publications, and basic science research isn't what you want to do. You've done outcomes research. People who have, people who say, "Well, I want to really do, take care of cancer patients in the poor community and the underserved community," but have never done anything like that. We kind of wonder how sincere they are, and so we really look for accomplishment and drive, and those are the two things, because we can teach you all the skills you need to do if you want to work hard, and so that helps a lot. We do have a lot of people who come rotate with us, and I know the same things from Memorial and MD Anderson and everything else. People go rotate there for a month just to sort of show themselves off. I think if you're good, that's something that works very well. I will tell you that it's for some of the fellowships, if you don't, and it's not ours, so I can say this fairly, if you don't go there, they're so competitive. If they've never seen you, there's a good chance you're not going to interview there, because there are just so many people who have done research there or who have gone there on rotations and everything else. So it can be very, very tough sometimes just to make the interview cutoff. And letters of recommendation mean a lot to us. Letters of recommendation from people we know, talking about people's technical proficiency and their drive and their desire to do well, and people who come in with a real scientific interest in the field, demonstrated through publications or outcomes research, really people who seem to have come to the conclusion this is what they want to do and have the outcomes and the results to prove it. So just very quickly, it's a 2-year fellowship. Some fellowships offer a third year in the lab, but now that we're ACGME, you have to do all your fellowship within 2 calendar years, within 24 consecutive months. Requirement is 120 cancer-specific cases broken down by case. This is going to change and ramp up very, very quickly, so that by the time everyone in this room who's a resident becomes a fellow, that number is going to be at least double that, with very strict criteria. There are rotations for a month of medical oncology, radiation oncology, and surgical pathology, so that you learn all the other areas. And now that this is ACGME, there is adamant protection of research time so that people can publish and develop research identities. Really, all the things I've talked about is why we did it is sort of what the career offers. You can do whatever you want out of this field. There are people who never practice surgery again and go purely into research. That's very, very rare. There are people who leave and go into highly specialized jobs. That is somewhat rare too. Most people are going into very good academic jobs with clinical and or basic science research that have the ability to then specialize over the first 5 or 10 years out. And really the thing that you don't get now as a resident as much is a high degree of comfort with complex care. And I think in these fellowships you get to do things over and over and over and get a very good level of comfort. And I think also that you'll see that when you start to do something for more than a 2-month rotation, that the rewards of interacting with patients over a long term is something that is very rewarding with regard to cancer patients. And I'll end there to keep everyone on time. I think we'll do questions at the end.